Welcome to week 3 of our adult intervention course. This week we're going to be looking at relational and common factors. And this will really constitute a slight pivot away from defining what evidence-based practice is and understanding what that is to one of our first focal areas for intervention. So in other words, one of the first areas that we might look at, and why this comes first is because, as you've read about, it's one of the most important areas, is the power of the relationship in helping people get better. So over the course of our discussion here in the next few lectures, and as you've read about, we'll talk about some of the things that constitute the relationship, why it's important, how it's important, and you'll specifically be introduced to a few of the more important relational factors in making your psychotherapy effective. So I want to remind you of how our course is organized and how you can kind of continue to try and make sense of what we're talking about and give it a place in your brain is how I think about this. How do I organize this and kind of give it a place? And one of the things that we said, and one of the things that I'll continue to emphasize, is I've organized our material based, number one, on what the focus of change is. What is it that I'm trying to change in therapy? Or what do I think is kind of influencing that change? And so this week, we're focused on the relationship. What am I doing in the relationship to produce change in my client? And I'm really trying to focus on and change the relational components of the work that we're doing. The second thing that I've said to you is that we will then explore various associated theories or conceptual models that are related to the focal area that we're looking at in any given week. And the really important thing of this is these models, these theories provide us with a conceptual understanding with what might be going wrong. Why is it that my clients are experiencing these difficulties? In this case, as you might imagine, we're going to deal with a lot of humanistic theories and actually some psychoanalytic and dynamic theories that have tended to focus in on the relationship and relational functioning and relational change. The third thing that we've talked about is like, what are the associated techniques, right? And this is the question, again, I think as beginning therapists, it makes sense that this is the question you hang on to more than others. But what do I do? Like, what do I do in therapy? And this particular theme, the relational theme, is probably the most challenging to a beginning therapist because there isn't a whole lot of necessarily what do I do. There's no like, do this worksheet, do this technique, do this thing. It's a lot of kind of thinking about, understanding, engaging, being active, being involved in the relationship that you have with your clients. And that tends to be some of the more kind of challenging things, not only for beginning therapists, but also for advanced therapists. And then finally, as we said, we're going to focus over the course of this semester on mechanism or principles of change. What do we think causes all this? If I'm doing all these things, if I'm thinking in this way, if I'm conceptualizing in this way, what do I think are the things that are actually leading to the change? What are the general mechanisms and principles that I can abstract from this, right? And so as a prelude to what we'll be talking about, forming a good relationship with another human being is restorative, right? Many of our clients, many of your clients will come from bad relationships. And for them to have a positive, accepting, caring, nurturing relationship with you in and of itself will be curative. Okay? So I want you to focus on these 4 things as we talk all through the semester. Every lecture I have from here on out, well, not every lecture, but every introductory lecture I have from here on out will introduce you again or remind you again of these 4 things. These are the 4 things that I want you to think about, that I want you to organize the information into, and that I want you to leave my class with a firm base of knowledge about. So one of the things you read this week was the first chapter from a book by Norcross and Lambert that looked at relational factors and discussed kind of where these things fit in a historical context. I love history in a way that we don't want to repeat it in some ways, and that we can learn from it. So you'll have to give me a little forgiveness here. I'm going to talk about kind of 8 historical factors here, and they're not all 8 historical factors, but 8 points in our history that really kind of speak to where we're at and where we've come from. And I'll start with one that probably doesn't surprise you all that much based on our readings even to this date in the semester. But for many, many years, the psychodynamic and analytic traditions kind of reigned. They were the thing to turn to when it came to doing individual psychotherapy. And one of the first challenges to that was the client-centered, Rogerian, humanistic kind of way of thinking. And the thing that they diverged from in relationship to the dynamic and analytic folks was this idea that people had an inherent ability to change themselves. And that given the right context, given the right facilitative relationship, people would make those changes and they would do those things that would benefit from them. This sounds almost like, of course, duh, like we all know that now. But again, we're standing on the shoulders of the people that came before us. And the idea now that if I'm given the right context, if I'm given the right environment, if I'm given the right relationship with a helper, that these things will come to me, was revolutionary at the time. And it really introduced a whole new way of thinking about psychotherapy, what psychotherapy was, and how we might do psychotherapy. The second thing that happened in the first kind of widely cited study regarding this effect was in 1975, and you'll note that this predated the Smith, Glass, and Miller meta-analysis, by the way. What they noted here, and this was what we call comparative efficacy studies. They looked at if we compare one therapeutic approach to another therapeutic approach, which one's better? And continually, with some exceptions, to be clear, the answer was they're all pretty good, right? If they've got a good organized theory and the techniques are kind of well outlined, they all tend to do pretty good. And this led to what's often referred to as the dodo bird interpretation. I'm not a big Alice in Wonderland fan, but this comes from Alice in Wonderland, or the idea that all have won and all must have their prizes. So in other words, all therapies are good, all therapies are effective or just about as effective. And then the question became, well, what do we do with that? If I'm selling you on my therapy is effective, my therapy is more effective than your therapy, what do I do with that? Like, how do I make sense of that and what comes from that? And what one of the things that came from that was the development of a society. And you'll notice throughout the history, like, these developments of societies, of organizations, of agencies kind of gave people a home to talk about this stuff and to kind of explore their ideas. And these homes that we have are really important. And it doesn't matter what home it is for you necessarily, but usually there are a number of like-minded individuals that share kind of common themes and ideas. And so the Society for the Exploration of Psychotherapy Integration, it's SEPI, I love it. It's international in scope, which I think speaks to, in some ways, how American culture said, oh no, we need to do, and in my opinion, like we need to do cognitive behavioral therapy. And the international kind of society has said, you know what, nah, not really. Like there's a bunch of other things. So SEPI is a really kind of internationally based organization. The one reason I haven't gone to it many years is because it's in foreign countries, and I don't get enough funding, and I can't pay for those conferences. But I'd really encourage you to check out the Society for the Exploration of Psychotherapy Integration. And the idea here is we need to tear the walls down and not kind of keep building the walls. So SEPI was an organization that was kind of formed, and it gave a voice to people that were thinking outside of the box of specific psychotherapy interventions, and has been wonderful in supporting those through the years. The other thing that kind of emerged over this time, and this actually has roots, most people forget about these roots, but it actually has roots back to Freud, who talked a lot about the psychotherapy relationship. As you know, it talked about countertransference, transference. But one of the things that came out of all of that research was this idea that, look, the alliance, the psychotherapy relationship, And again, I'm going to distinguish between the alliance and the relationship, but here we're talking specifically about the alliance, had a great deal to do with outcome. And this kind of finding in the early days was repeated over and over and over again. And it led people to think of, well, what's going on here? What's the importance of the alliance and outcome linkage? And if the alliance is common to all different types of psychotherapies, are there other things that are common to other or different types of psychotherapy? All right, I'm going to try and pick up the pace here. So this led to one of the great debates you, I think, talked about in Dr. Angeloni's class, this kind of idea of like common versus specific factors, which is more important. And it led to great debates. Like there are great debates about this. No, it's the common factors. No, it's the specific factors, over and over and over again. And what we've read about this week is common factors tend to win out, right? They tend to be more important than specific factors. And so this, again, kind of opened this door to the task force that you read about this week. Started in, the first one is 1999. There was one in 2019. I'm sorry, 2009, and then one again in the 2019 to 20 is when this data started to emerge. So they tend to do this every 10 years. In this task force, much like the Division 12 task force from APA, much like the task force that was associated with the development of evidence-based behavioral practice model, the idea of these task force was, hey, we know relational factors are important. Can you guys get together? And by guys, I don't mean just guys, sorry there, but can you people get together and look at the literature and tell us as a field what might in fact be more important, less important, validated, supported, whatever terms, we'll get to those terms here in a second, but whatever terms we want to use to indicate to the field that these relational factors are more important than other relational factors. In the same way that Division 12 said, can you tell us what particular treatments are more important, more effective, more impactful than other types of treatments for specific disorders? What this task force has developed, and it's gotten larger and bigger as you might expect over the years. It is now a 2-volume book versus a 1-volume book, which pissed me off because I have to pay more money for the 2-volume book than the 1-volume. But enough about me. What they did was they looked at kind of two factors here. They looked at relational factors. So what factors are important in the relationships that we develop, and how do those influence the outcome and process of psychotherapy? And then they also looked at what they call adaptive factors. One of the adaptive factors you read about this week are cultural factors, for example. So how might I adapt my treatment based on some characteristic, demographic, or otherwise of the client that I'm dealing with? The other thing that you read briefly about is, briefly or maybe in depth, depending on the time you had this week, but you looked at reactants, right? What do I do if I have a reactive client, and how might I modify my treatment based on those? So these are, if you're familiar with the term of moderation variables in psychotherapy, these adaptive factors are moderation variables. How do I moderate my treatment based on some third variable that my client has or possesses or is, I don't know, or all of those? And all of this led us to what we think of as a more refined view of what makes psychotherapy effective, right? And as you read about, and as we'll talk about, this led us to, as a field, kind of define the differences between what are client factors, what do our clients bring to the table, what are therapist factors, what do we bring as therapists to the table, relational, how do those things interact with one another, and then the method and technique. You've also looked at and read about what expectancy factors are and how those are important to psychotherapy. And then finally, there's just this kind of random unexplained variance. We don't know what the hell's going on. We'd love to say we know it all. We don't. The world happens in mysterious ways. And when I'm doing this lecture, it's a cold, rainy day, and I don't know, I don't feel as good as it did yesterday when it was nice and sunny and a little bit warmer. All of those things kind of influence who we are, what we do, and how psychotherapy might be functioning, and how we might be functioning in psychotherapy. And this leads us to the classic question, and I pose this because it's not answered. We don't know what the answer is, but the classic question that you hear, and it was posed in 1967, which means It's been around for a while. Nobody knows exactly the answers. We're always getting closer. That's the way science works. But the question is, what treatment by whom is most effective for this individual with that specific problem and under what set of circumstances? And if you've done any research, which all of you have, all of you are, you know that if I'm trying to develop an experimental manipulation of all those things, it's really, really difficult. And so these answers are really, really complex. The designs are really, really complex. But what I hope you walk away from in these coming lectures is a good sense of what we know right now, because we actually know a lot. We don't know it all. There's a lot more unexplained variance out there than there is explained variance, but we know a lot about kind of what you can do to make psychotherapy effective and how you can do that within the relational context of you and your client. So before we jump into kind of specific relationship factors, we have to define what is the actual therapy relationship. And you're going to hear it in your sleep. You're going to, be really happy when the semester's over and you don't have to have me ask you this anymore. But as I've said over and over again, because I think it's really important and a lot of therapists misunderstand this, there's a difference between the therapy relationship and the therapeutic alliance. A lot of people confuse it, and if you ask a lot of people and you go, what's the therapy relationship about? Or you even go, oh, what's the therapy alliance? They'll go, there's no difference, number one. And then they'll go, oh, it's all about building good rapport. And it's like, nah, nope, it's a little bit more fine-tuned. It's a little bit more specific than that. And so I'm hoping that you're not one of those people that will kind of perpetuate that idea, and you'll come to a better understanding of what not only are those differences, but what the therapy relationship is. So let's start with a very, very basic definition. And this is one that was introduced in 85. It's been refined in 94. It's probably been refined after that. But the idea is the therapeutic relationship is the relationship that is the feelings and attitudes that the therapist and client have toward one another in the manner in which these are expressed. Simple enough, generic enough, doesn't really tell you a whole lot other than it's this kind of interactive thing that you and your clients have together. It's what you do to them or with them, what they do to you and with you, and collectively those things, as we will learn, are important to making psychotherapy effective. One of the other things that you read about in Norcross and Lambert, and you'll hear this discussed by any psychotherapist worth their salt, in my humble opinion, is that, look, therapist factors, client factors, relational factors, technique, all these things that we're talking about don't exist in a vacuum. I don't walk into a therapy session and go, you know what, I'm only going to do this technique and my personality and me as a therapist has nothing to do with it. No, of course not. Right? All of these things are synergistic. They work together in I don't know, hopefully harmony, maybe not at times, but they work together. If I'm a total jerk and I'm trying to do a technique that I know to be effective, well, you're not going to be able to do it. There's a great example. They say this in your reading, this great example, and I know it having raised children. If my children don't like me and I'm trying to get them to clean their room, it's the example that you read about. Well, I can be the best technician. I can use the best behavioral principles. I can use the best reinforcement strategies. But if my kids don't like me, they don't respect me, those are going to be less effective, right, than they would if I'm in a good relationship with my children. They know that I'm going to listen to them. They know that I love them. They know that I care about them. Then my discipline strategies, my all those things are going to just work much better. So these things don't exist in a vacuum. They work together, and ultimately, as a good psychotherapist, you're going to have your eye on each of these factors as you go through doing, hopefully, a good psychotherapeutic intervention with your client. So what exactly does the psychotherapy literature tell us about what, in fact, makes psychotherapy effective? And this literature is really important to understanding why myself and others who know this literature, maybe believe this literature, focus in on relational factors. It's why we're talking about them first over the course of our semester. It's why you had a whole semester kind of focused on psychotherapy relational factors and how to do that. And we're going to start over here on the left-hand side. And this is in my experience is really confusing to students as to why these two diagrams are different. So let me try and explain it to you. On the left-hand side here, we have a diagram that represents all of the things that we know to predict outcome variance or variance in outcome. So in other words, if I can predict 50% of the variance correctly, how does that 50% get divided up? Right? And so obviously I've got mine in another way. If you talk about this statistically, this is known variance. What are the things that we know to predict psychotherapy outcome? And when I divide that out, I get this kind of extra therapeutic change. Again, I always start here because it always reminds me that no matter how good of a psychotherapist I am, there's only so much shit I can control, right? There's a lot of things that are going on outside of therapy that influence my clients in their lives and the work that I'm doing. And that's really important. 40%, it's the most. The other thing, if we jump over here, are common factors. Common factors combine, as we've been talking about it, client factors, therapist factors, relational factors. There are these things across different treatments and different therapeutic approaches, different theories that they have in common. The therapeutic alliance goes in here, right? Reactance goes in here. Cultural factors go in here. Right? And then the other thing that we talked about is techniques, right? Techniques here account for about 15% of the variance. And then the one, we're going to kind of gloss this over, but the literature kind of indicates that these expectancy or placebo effects are important. The thing that I'll say about this right now and here is that we can do things to increase a placebo effect or to increase our clients' expectancy of our treatments being better. Like we can, like I'll often say to people, look, what we know is that psychotherapy is really effective at the issues that you're dealing with, or the problem that you came here with, or the thing that you want help with. And we know that those treatments take some time. Traditionally, in even the best of circumstances, it's about 16 weeks. But people get better, and we know psychotherapy is effective. I'll say that directly to a client to increase that expectancy effect, or to increase that. I'm not going to lie to them, right? I'm saying that based on my knowledge of the literature, but increasing that expectancy and those that expectation of positive outcomes is really important. And then we'll go down here to techniques, right? And this is the thing, again, I don't know how many times I've said it. I wish I had $1 every time I've said it to you already this semester, but our techniques are important. They only account for about 15% of the variance when we consider all of the variance we know of, all of the accounted variance. It's very little, right? Period. Not unimportant, just placing them in their proper context. Now we go over to the right-hand side here, and what we have here is we're going to take all the variance. And you can see, right, starting right over here, we have the unexplained variance. And all of this stuff over here is the explained variance. So now we have the explained variance, what we know to be impactful in psychotherapy. And then we go, all right, now let's add in let's add in the stuff that we don't know about. Right, let's add in the unexplained variance. And again, a very humbling thing here is the unexplained variance accounts for about 40% of the variance. So there's a lot going on in psychotherapy. There's a lot going on that helps our clients to get better that we simply don't know about. It's not that we need to give it up, right? I mean, if you're a psychotherapy researcher and you go, oh, we don't understand about 40% of the variance, that's great, because I got a lifetime of work to do to help explain that 40%. But then we go, all right, well, let's break down these common factors. And we go, all right, which one of them is kind of the most important? And we go, as we've said already this semester, patient contribution, patient factors, 30% of the variance. Holy cow. Our patients have, and you read this week, when we go, all right, let me look at how the patient rates the therapeutic alliance, or let's see how the patient rates empathy, and then let me look at how the therapist rates empathy. It's almost always invariably the client's perception, rating, and understanding of these variables that's more important than the therapist. Tells us that our patients are really, really important. Clients, same word here, right? And then what's next? Therapeutic relationship. All right, so sorry for the clunkiness here. I'm still trying to figure out exactly how to edit stuff here. So I just went to a new slide to pick up where I left off. And where we left off was we said, okay, look, unexplained variance, a whole bunch of stuff, patient contribution, a whole bunch of stuff. Like if you look at this, 70% of the variance in psychotherapy outcome is between unexplained and patient contribution. That's a lot. And then where I got thrown off a little bit was I looked at this and I go, therapy relationship, 12%. I even doubted myself. This is why I tell you guys that this is important. This refers to all of these relational factors. It is not the therapeutic alliance. It's all the relational factors that we're going to be talking about over the course of this slide. 12%. Treatment method, 8%. Okay. And again, you can see, right, this has less variance. This confuses a lot of students. We go, wait, I thought you said it was 15%. Now you're saying it's 8%. Well, that's because we took all these kind of common factors and we parsed them out into the patient, into the therapist, into the relationship, and we kind of divided that. I know the numbers don't equal out. Don't even try to add them up. It'll make your head hurt. The idea here are some simple takeaways that I'll talk about here in a second. So therapy to relationship, treatment method, and individual therapist are almost the same in terms of the variance, and then there's these just other factors. Don't ask me again what, sorry, that sounded weird. Don't ask me what an other factor is compared to unexplained or extra therapeutic. I don't really know. Like, some of these things are just the best estimate we have based on our scientific literature. So don't get obsessed in the details here. But what should you take away, right? And I've alluded to these as we've gone through this. What should you take away? There's a lot of stuff we don't know and a lot of stuff that we don't have control over that are influential in our or not in our clients doing good in psychotherapy. We know that the patient themselves are really, really important to doing that, and that the techniques always, the method or techniques always kind of come out at the lower end, right? And it's the thing, again, that you're probably the most obsessed with. What do I do? How do I do it? And I will continue to tell you, don't worry about how to do it. Be in a good relationship, facilitate your clients' outcomes, and understand the impact that you have on your clients, and facilitate this expectation of treatment going well. If you look at page 13 in your readings, it's the actual first full paragraph on there. And they say, how can psychotherapy be improved? Follow the evidence, follow what contributes to psychotherapy outcomes, begin by leveraging the patient resources and self-healing capacities, emphasize the therapy relationships and so-called common factors, employ research-supported treatment methods, select interpersonally skilled and clinically motivated practitioners, and match all of these to the patient characteristics, personality, and worldviews. This is not simply matching treatment method to a particular client disorder, period, right? That's kind of the takeaway. It is not just picking the best available treatment. It's about all of this other stuff. All right, I hope that makes sense. I read that really quickly to you, but again, that's on page 13 of your readings. It's the first full paragraph on that. So we noted that the task force, and you read about this, that how the task force was divided, what they did, they reviewed the available literature, they were given guidance on how to do that, et cetera, et cetera. The things that you have to read for this week are the meta-analyses that came out of those committees' reviews on the particular constructs and concepts that they were asked to review. It's really interesting. These meta-analyses are part of the book chapters if you buy the book, but they're also available in the popular literature, in the literature for you to review. So those are some of the things that you read. As we've talked about, the task force said, look, we want to define both the elements of the relationship that are known to be effective, as well as these methods of adapting. So how do I adapt treatment based on particular characteristics of my clients? And they, as a lot of these task forces do, they picked their own way of describing it, but they settled on demonstrably effective, easy for me to say, probably effective, promising, but insufficient research to judge. And you can see, right, why does Dr. Haas talk so much about the alliance? Why does he want the alliance to be something that you recognize as different than the relationship? Because alliance in individual therapy, youth therapy, and family therapy is found to be demonstrably effective. I'll get that word right the second time. In terms of the psychotherapy relationships. We also talk about cohesion in group therapy. That's beyond the scope of our work. Empathy, when Dr. Haas says, do you listen to your clients and be a good human being? Empathy is a part of that. You can't be empathic to another human being if you don't first listen to them. Right? Start by listening, and if you can listen, you can then be empathic. Collecting feedback. How is therapy going for you? Let's find a scale. Let's find a way of, and I like objective and well-developed scales. I don't necessarily care as I'm teaching you psychotherapy. If you simply say, look, how much distress are you in this week? On a scale of 1 to 10, a scale of 1 to 100, I don't care what the scale is, pick it collaboratively with your client. Scale of 1 to 10, how much distress have you experienced this week? 8. Well, what was it last week? 9. Oh, things have gotten better. What's different this week than it was last week? What's our goal for therapy? To get you to a 2 reliably, a 3, a 5, a 1, a 0? 0 is hard, but whatever it is, we pick that collaboratively with our clients. So collecting that feedback and monitoring what you're doing based on that feedback. I won't go through all of these because you can read them and you're really smart people. But I will note agreement on goals, agreement, working collaboratively with your clients. We've said those over and over a number of times already this semester. You'll probably hear about them more and more. Those are both important. Some of these that you've heard about, right? Congruence, genuineness, repairing alliance ruptures. We've talked about that. There's some evidence here, just not sure what to say. And then, and I'm sorry I'm jumping around, I'm trying to go really quickly here. We can talk about these in class. There's this method of adapting. Why did I have you read about culture in reactance? Because those are really two of the demonstrably effective, got to slow down to say that, relational factors. So in other words, what is reactance? We'll talk about that in our next video lecture. We need to vary how directive we are based on the reactance level of our clients. Culture incorporates a whole host of different things that we might do differently, but we want to ensure and make sure that we are dealing with our clients' culture. Preference is a huge one. It's part of why I research it. All right, I can talk a lot about these stages of change, coping style. These are both really important. I keep saying these are all really important because they are. Basically, everything up here is really important. These things may be important and things that you want to be aware of. But this is the results from the task force. So what you've seen right now is you've got this task force that says, look, you should look at these relational factors. You'll notice that these aren't specific to any particular diagnostic label or category or presenting problem. These are studied, as most relational factors are, as general relational factors that cut across different diagnoses. They cut across different presenting problems. So these are general relational factors, in contrast to the Division 12 and the Tolan articles, where we're looking specifically at different treatment techniques as they're related to different clinical presentations. So different way of looking at things, but both of the task force come with this list of things that you kind of should do. And that's one of the things that you noticed in your reading, is that at the end of that reading, there was usually this list of like, here's the way that you might incorporate this into treatment. which is really helpful, except as a beginning therapist and even as an experienced therapist, it's like, okay, now I've got a list of treatments that I should know, and then a list of things that I should do in the therapeutic relationship. And as we'll learn, all right, then there's also these general principles. And after a while, it makes my head hurt, and I get a little confused about exactly what I should be doing. I'll try to get you more comfortable with that as we progress over the course of this semester. It is not uncommon for your head to hurt right now and for you to be going, wait, what the hell am I supposed to be doing in psychotherapy again? And hopefully by the end of the semester, you'll feel much better about that. So I'll remind you, and I left this slide in here intentionally, the goal of these video lectures is for you to be thinking about, for you to get some lecture material, for you to kind of get the basics of the information that we've talked about. And the whole idea of this is for you to be able to come into class and for you to be able to discuss, talk about, make sense of it, struggle with it. We'll do some role plays. We'll talk about how this actually translates into practice. But the whole idea of you listening to this prior to lecture, and this week's the exception, obviously, because I'm away, but in general, the idea here is for you to kind of listen to these things, to be thinking about them, to be understanding how they fit into the reading that you've read for the week, and to highlight some of the important things that you can look back to in that reading. But I'm hoping that after you finish our lectures or during the middle of it or whatever, you're jotting down ideas, you're jotting down things that excite you, that interest you, that confuse you, so that we can use our class time to discuss these things in greater depth and greater detail.